Welcome to All Things Cardio-Oncology. My name is Steve Caselli. I'm the Executive Director of ICOS. And in this podcast, you'll hear from a diverse representation from our community. We want you to be both informed and inspired by their stories and experiences, and we're so glad that you've joined us today. Well, I'm joined again today by my co-host, Dr. Dan Lenihan. He is the founding director of ICOS, and he's serving as the cardio-oncology lead at St. Francis Healthcare System in Cape Girardeau, Missouri. Welcome, Dan.
Thank you so much, Steve. I'm very excited to listen to what our great colleagues in Europe have been doing.
Yeah, we are really delighted today to welcome Dr. Sebastian Schmidt from Warsaw, Poland. Sebastian is a great friend of ICOS, and we were saying he's a world champion, a world globetrotter for cardio-oncology, speaking and promoting cardio-oncology all over the world. He is the cardio-oncology lead at the Center of Postgraduate Medical Education in Otwock, Poland. So welcome, Sebastian.
Thank you. Great pleasure to enjoy this conversation.
Sebastian is also the chairman of our education working group here at ICOS, so we always enjoy having him with us. And our special guest today is Dr. Isabelle Mahé, who is professor of internal medicine at the University of Paris. She is head of internal medicine department there at a teaching hospital. She is the first author and the principal investigator of a clinical trial on the use of apixaban for cancer-associated VT, which is what we were going to talk about today. So welcome, Isabelle.
Well, thank you very much for the invitation. I'm very happy to be here today with all of you.
We are so happy to have you. And I wonder, when we have a guest on the show for the first time, we often like to hear just a little bit about your history, your background in terms of your medical experience, and in particular, how did you get interested generally in the field of cardio-oncology?
So I have to tell that I am a specialist in cardiovascular disease by training. And then I became professor in internal medicine, as you mentioned before. And in my department, there are many units, internal medicine, of course, but also unit of cardiology, cardiovascular disease, and oncology. So it was very important to me to see the evolution, how oncology patients could change over time. And I could see that management changed over time, and that treatment changed over time, and resulted in a fantastic improvement of prognosis and life expectancy. So I could see that in my practice. And on the other side, I was always interested in anticoagulant management and trying to identify the optimal anticoagulant options for patients who are both at risk of thromboembolic complication and hemorrhagic bleeding complications. So I had to work in elderly patients, in patients with renal impairment, and now I'm working more on the patients with cancer.
Thanks for that background. That's super helpful. And I think that's probably a good lead then. I mean, obviously your personal interest in anticoagulation was part of this leading up to this study, but tell us a little more about how the APICAT study came about. What was the issue that you were seeking to address in this trial?
So a few words about context once again. The first point was about the life expectancy of patients with cancer-associated thrombosis, which is improving over time, and questioning the optimal management of those patients beyond 6 months, because first of all, clinical trials addressing the question of cancer-associated thrombosis focused on the first 6 months. And for a long time, the prognosis for those patients was not beyond 6 months. They were quite all diseased within the first 6 months. So with the progress of anti-cancer treatment, we could see those patients surviving the first 6 months. And what next? How should we manage those patients? No clinical trial was available, only observational study with very few patients. And we could see from the study that the risk of recurrent VTE declines over time, while the risk of bleeding remains quite substantial. And in this context, guidelines suggest continuing anticoagulant, but no word about the dosage in those patients who are both at risk of VTE recurrence and bleeding. And the question is, could we optimize the anticoagulant option in order to prevent the risk of recurrence and minimize the risk of bleeding? That was the challenge addressed by the APICAT study. So we hypothesized that a reduced dose of anticoagulant beyond 6 months could be as effective as and safer than a full dose anticoagulant for extended treatment.
So, Sebastian, I know you probably have lots of things to chime in about here, and maybe if you could briefly tell us a little bit about your history, although I certainly know it personally, and we just want to hear how you ended up getting involved in this study as well.
Thank you, Dan. As you know, I have worked together with Professor Torbicki in Poland in the Department of Pulmonary Circulation and Thromboembolic Diseases. And together with Professor Torbicki, we participated in the Caravaggio study. That was the introduction to the APICAT study. In Caravaggio, we confirmed that apixaban may be so effective as dalteparin, low molecular weight heparin, and we confirmed the same safety. And after that study, at the end of this study, when we're finalizing the Caravaggio study, Professor Mahé invited us to enjoy APICAT study as the continuation of the Caravaggio. We continue the treatment anticoagulation with apixaban, but we compare the reduced dose to the full dose as long-term anticoagulation beyond the 6 months of anticoagulation. And so that is the short story of my activity at the beginning for the Caravaggio study, later for APICAT study. And of course, we cooperate together with Professor Mahé for the next study, together with Professor Eric Klok from Netherlands. We enjoy the Serenity study. So this is our story for anticoagulation in cancer patients.
Yeah, I think it's always hard for me to sort of sift through the alphabet soup of, anticoagulation studies, especially in patients with cancer, because, there's this study and that study, and they each looked at different things. And so trying to just keep it all straight is a real challenge. So Dr. Mahé, I wonder if you could tell us briefly, say 3 or 4 main points of that APICAT study.
So, first of all, as Professor Smith mentioned, so it was a collaborative work. So, to address the issue of extended treatment, we set up an international prospective randomized control study. It was a double-blind study. It's very important to stress in this setting of VTE because in those patients at high risk of both recurrences and bleeding, we could, in case of an upper-blind design, suspect more recurrences in case of reduced dosage and more bleeding in case of a high dosage. And here, the double-blind study is a very strong point in favor of valid results for this study. And a large number of patients was requested to demonstrate the first step, which was a non-inferiority, comparing the reduced dose as the full dose of apixaban, and then in the second step to demonstrate the superiority of the reduced dose as compared to the full dose. So we had a lot of work altogether because more than 1,700 700 patients were required in order to demonstrate those both very important objectives, and that's the reason why we try to recruit patients in many countries, 11 countries, then in Europe and Canada. It's very important for the representativity of the recruitment. Both oncology and cardiovascular disease centers were a part of this study. So the setting and the construction of the study was very important. It was very important to me to involve all key leaders and countries involved in management of cancer-associated thrombosis. So then this study was difficult to conduct because an international study is not so easy to conduct. Many issues, but we did it. We had the pandemic in the middle of the study, but we succeeded in completing the recruitment, the whole recruitment, and to be able to provide the conclusion to this very important question of the optimal anticoagulant manner to manage those patients. What is the best option, full dose or reduced dose? And the main conclusion was very clear in this study. The first step, as I mentioned, was to study, to demonstrate the non-inferiority. Why this first step on non-inferiority? Our objective was not to demonstrate that the reduced dose is superior to the full dose, not at all. We wanted at the end to demonstrate that the reduced dose was safer than the full dose. But we didn't want to demonstrate it at the cost of an excess of VT recurrence. The VT recurrences in patients with CAT are the most feared complication for those patients because they are a very serious complication, and patients could die from VT recurrences. So it was very important to be sure that when with dose reduction, that dose reduction was not associated with an excess of VT recurrences. That is the objective. That was the objective of this first step, demonstrate the non-inferiority of the reduced dose as compared to the full dose. We succeeded in demonstrating this objective. The rate of VT recurrences was very low in both arms, very similar rates of complication. So reflecting that the low dose is effective in those patients. And in the second step, we could demonstrate that the reduced dose of apixaban results in a significant reduction in the risk of clinically relevant bleeding, 25% of a reduction of clinically relevant bleeding made of major bleeding and clinically relevant non-major bleeding. So the objective was met, providing important results for practice because patients are well protected from VT recurrences and have less bleeding to have during the follow-up. So important for clinicians and patients.
Right. So if you have, if it's clinically acceptable, according to your study, to after 6 months of effective treatment, that you can go to the reduced dose, is from your study, and I guess extrapolating to clinical decisions, is there a patient profile that is very amenable to being able to use a reduced dose, or was it all patients with cancer? Was there a particular subset or subgroup that seemed to benefit from the reduced dose, or maybe they had a higher risk of recurrent VTE. I mean, was there any subgroup that was concerning, or was just all patients?
It's a very important question you're asking. So I think that the results of this study can be put into practice for patients with the similar inclusion criteria than those of the APICAT study. At the end of the study, we looked at the different patients' profile in terms of site of cancer. I have to stress that stratification was performed according to 4 sites of cancer: breast, colorectal, prostate, and lung cancer. Those sites of cancer are the most frequently encountered in patients with extended treatment for CAT. And we had a look at the different sites of cancer. We had a look at different subgroups in terms of patients' characteristics, and we couldn't see any subgroup of patients suggesting that the treatment effect could be different. So we can say that the results of the study can be extrapolable to the population included in the APICAT study without difference according to the site of cancer or patient characteristics.
If you or your institution would like to have credentials that confirm your qualifications as a cardio-oncologist or a cardio-oncology center of excellence, we encourage you to consider applying for our certification exam in cardio-oncology or our certification for centers of excellence. These are the only certifications currently available in this field, and it's a special opportunity for you or your institution to distinguish yourself, recognizing your expertise in the field. More information about both these opportunities can be found at ic-os.org, or you can email directoricos@gmail.com for more information.
Yeah, so one other general concept is, if a person has a GI malignancy, especially pancreatic or gastric, that they certainly have a high rate of recurrence of DVT, or DVT-PE, that would be a major risk, one of those cancers. But it's also the group that's more likely to have major bleeding. So, and it's kind of like it's a really difficult, two-edged sword there, whether if you reduce the dose in that higher risk population, they may be exposed to a recurrent thrombosis, which would be a problem, but also hopefully you would reduce their chance of GI bleeding. I mean, is there any conclusion from that, or was there just not enough patients in that category of cancer that we could say we learned anything from?
So once again, it's a very important point you're raising now. So once again, in our population, reflecting the patients managed for extended treatment, the risk of recurrence was low in both arms, 2.1% and 2.8%. So it is 12-month cumulative incidence for VT recurrences in the low dose and full dose of apixaban, respectively, and no way to think that this treatment effect could be different in a site of cancer or another. But very few patients with pancreatic cancer and gastric cancer were included. The reason is those patients are not so often surviving 6 months of anticoagulant after VTE. So our population reflects those patients with extended treatment, and patients with pancreatic and gastric cancer are mostly deceased during the first 6 months. So it can explain probably that those patients were not so those patients who were included with such site of cancer were at better prognosis with control disease, because some anti-cancer treatment could be effective in certain types of pancreatic cancer, but that is not the majority of them.
So, Sebastian, how do you see this study as, how is it changing your practice? Like, what conclusions do you make, or when you have a patient in front of you, how do you incorporate this information into your decision?
Mm-hmm. Thank you, Dan, for this practical question. Till the moment of presentation of the results during the Congress of American College of Cardiology, we know the guidelines, ESMO guidelines, ASCO guidelines, guidelines published by European Society of Cardiology, and each document recommended to continue anticoagulation with the same doses of anticoagulation in patients with active cancer disease. Of course, we can discuss about the definition, appropriate definition of active cancer, but we had to continue anticoagulation with therapeutic doses. When Isabelle presented the study, APICAT study, first time during the Congress, and the concomitant publication occurred in the New England Journal of Medicine, everyone knows that we can reduce the dose in patient anticoagulation in patients with cancer disease, active cancer disease, when anticoagulation should be continued longer than 6 months. This is very important because I observed earlier many rates of bleeding in my patients, because when we continue the subsequent lines of anti-cancer treatment, we can expect the overlap of different toxicities, for example, renal dysfunction, liver dysfunction, and frailty syndrome, of course, sometimes thrombocytopenia. And our patients experience bleeding. Now, I observe the minimal rate of bleeding because I reduce the dose of anticoagulation, for example, apixaban, to the dose 2 times 2.5 milligrams per day. And in this way, I can significantly reduce the risk of bleeding. And this is very practical study which changes my practical everyday decisions.
And then I guess one other question that comes from the study, I mean, there probably are several, but what about patients after 1 year of therapy? I mean, is this indefinite therapy, or is there some interval that we might say, okay, they've gotten long enough? Or if anybody's, quote, still getting active cancer treatment, they probably should stay on anticoagulation forever. How do you guys see the longer term question from, based on what you got from this study?
Excellent question, Dan. To be true, we don't know where is the appropriate decision. We remember the data from Hokusai study, and when this study was 2 months, the duration of this study was 12 months. And we observed the separated arms of the efficacy regarding the efficacy, and we could conclude that the oral anticoagulation was better in comparison to low molecular weight heparin. So the decision to use new oral anticoagulants for long-term anticoagulation seems to be better regarding the efficacy and regarding the quality of life of patients, because they use only oral drugs instead of infection with low molecular weight heparins. But we don't know how to understand the efficacy beyond the 1 year or 2 years. And that was one of the main reasons to build a next study. As I mentioned at the beginning of our discussion, we are performing the Serenity study together with Isabelle, and in this study we will confirm when the anticoagulation should be continued and when to stop the anticoagulation, because the risk of bleeding is significantly higher in comparison to expected benefit. So I believe that during the next upcoming months, we will define the moment when we should stop anticoagulation and when to continue, because the benefit may be higher in comparison to risk of bleeding. So everything before us.
So Isabelle, so you did this beautiful study and you presented it now at major congress and publication, et cetera. And so as one of the things that I certainly learned firsthand, with any clinical trial is, you work so hard, you organize it, you get it done, all the colleagues that are working with you together, you're really working really hard, and it sounds like you had to get through COVID and all that. So that kind of added a new layer of difficulty to doing the clinical trial. And it's like one of those things, you get this nice presentation and publication, and then you go, okay, now what am I going to do? So now what are you going to do? What's the question that is most pressing in this space for you at this point, knowing what you know about the EPICOT study?
Oh, I think there are so many things to do in the field of cancers. Well, of course, so questions are numerous, and so the fact that we are asking what we should do beyond 12 months illustrates the major change we are living with those patients, because once again, 25 years ago, they were all dead after 6 months. And now we're asking, what after 12 additional months? It's fantastic that we manage those patients with anti-cancer treatment, but also with our anticoagulants very well, and it results in an improvement of prognosis for our patients. Fantastic. So many things to do. I think for patients, for example, with intracranial tumors, because they were not included in the EPICOT study, those patients is a specific population we have to work on. Patients at the end of life, as Sebastian mentioned, it is in progress with the Serenity study. And I think also that we have to work on the prophylaxis in those patients, because we are now speaking. We are discussing today the way of treating patients with VTE, but could we prevent the occurrence of VTE? Some studies are available, but we have not yet identified the optimal way to prevent VTE. It would be fantastic, and the dream to prevent the occurrence of VTE. And I think we have to further work on this issue and identify patients at highest risk to suggest for them prophylaxis. It is another way of research.
Super.
Yeah, thank you both so much for spending the time with us today to talk about this study, and congratulations again on the great work you've done. And as Isabelle said, there's plenty more work to do, and we really look forward to collaborating with both of you going into the future with further research. So thank you for being with us today. For more information about ICOS, you can go to ic-os.org, where you'll find more information about all of our programs, including our weekly webinars, our board certification exam, and other resources that we know you'll find helpful. Thanks for joining us today, and we hope to hear from you soon.
Free audio post-production by alphonic.com.